Welcome. My name is Dr. Paul Finger, and today we'll be speaking about ophthalmic ultrasound imaging with a focus on ophthalmic oncology. All of my teaching and research is supported by the Eye Cancer Foundation. I have no proprietary interest in any of the subjects or machines that are used in this lecture. I would like to take a moment to attribute some of the figures and a lot of the concepts to this book. This was the first book that I used to learn ophthalmic ultrasound imaging, and I highly recommend it. It's been republished by JP. You have to know a little bit about physics to be a good ophthalmic ultrasonographer. You have to understand why you're seeing what you're seeing on the screen. Some basic things, just three. Wavelength. Long wavelengths have greater penetration. We know this from light. It's also true in ultrasound. Shorter wavelengths have less penetration, can see things closer to the surface with higher resolution. The second concept is acoustic impedance. Here we're talking about the relative density of tissues. So an ultrasound wave goes through one tissue into another tissue. It could either reflect a great deal or little at all. That has a lot to do with the relative density of the two tissues through which it is going. An example of this would be hyphema. This aqueous is basically water, and the lens, as you know, has density. Therefore, this interface will have a high acoustic impedance. Blood is more similar to lens. Therefore, there'll be less reflected sound, and this spike here would be lower. These are some clinical examples. Here's the eye. And here's a choroidal osteoma, where the vitreous has low impedance, and then it hits the high impedance osteoma, which has such a high reflectivity that it causes shadowing in the orbit. Here's an A scan showing the high reflectivity of that tissue. And here's another clinical example where we have a tumor in the eye with lots of spikes of high reflectivity with shadowing into the orbit. This is a retinoblastoma. Another, and the last major point on physics I'd like to make, is the angle of incidence. If you have your ultrasound probe directly against an object, it'll reflect a lot of sound, and you'll have a very bright, crisp image. If you're not directly at the object, some of the sound will be reflected away, and you'll have less information coming back to your probe to create the image. And the farther away you are from the tumor or object, more sound is reflected, and you have a poor image. It's also true that if what you're imaging is round, some of the sound will be reflected away, or if it's irregular, or in fact, if it's small and very highly reflective. So in review on ultrasound physics, we have wavelength, where the longer wavelengths are used to look at the back of the eye or the orbit. Higher wavelengths are used to look at the front of the eye, the ciliary body, the cornea, and iris. Acoustic impedance, which is the relative density of materials, which can affect the image that we're looking at. And the angle of incidence is how you place the probe on the eye opposite the lesion to get the best possible image. What types of ultrasound are there? Well, back in the day, there was just an A scan. An A scan is basically a pencil of ultrasound that goes directly across like a laser beam. It spikes every time it hits an acoustic interface, and we use those spikes to measure distance. And we also can use that ultrasound to look at the internal reflectivity of tissues, which becomes very important in ophthalmic oncology. Here's an example of the most common use of A-scan. Here's an A-scan probe placed on the cornea. Here's the lens. Here's the back of the eye. Ultrasonographically with A-scan, we see the cornea. We see the anterior lens capsule, posterior lens capsule, anterior, posterior, and then all the way back through the clear vitreous to hit the retina and sclera. These distances can be measured for intraocular lens measurements. If we put this probe through the pars plana, not through the front of the eye, you see that the lens spikes disappear. So another way of looking at A-scan in terms of ophthalmic oncology is to use it to look at the inside of the tumor. In these three cases, we have different internal reflectivity within the tumor by a scan. Here's the tumor spike, the apex, sclera, and this is what's inside the tumor. In this case, we see a 45-degree angle going down and a very homogeneous tumor. That's melanoma. In contrast, this A scan, we go to the tumor apex and the sclera, and it's very high internal reflectivity. That's consistent with choroidal hemangioma, where there's a lot of vascular spaces in the tumor for reflections. Lastly, we have an example where we have the apex of the tumor and random spikes in between. This is classic for a metastatic cancer, where say, breast or lung has fibrous septae, which would be in the tissue causing those intermediate spikes. The next generation of ultrasound involved taking that A scan and putting it on a rotating arm, thus cutting a two-dimensional image through the eye. So here we have this two-dimensional image of the eye, where we have the back lens spike, the back of the eye, the optic nerve, all in one image. With this 2D image, we can start to reconstruct a three-dimensional picture of what's going on inside the eye. But we need a third instrument to do that, and that's our brain. Now, in order to take a two-dimensional cut through an eye, or multiple two-dimensional cuts through the eye, and process that, we have to optimize our clinical situation. You see here we have the observer looking at the screen and being able to see where the probe is on the eye and to see what direction the eye is moving in. It's really important that both the probe, the screen, and the observer are all in one field. Think about it. If you're trying to create a three-dimensional image of the inside of the eye and you have your hand over there and the eye is over there and the screen is over there, there's no way you can tell which direction the eye is looking or where the probe is on the eye. It all has to be in the same place, where you have the eye, the probe, and the screen all in one field. It's also important to know your equipment. Each one of the ultrasound probes either has a dot or a line on the side. That indicates where the top of the screen is. So that dot or line needs to be oriented in order for you to understand when the probe is on the eye, what slice you're making. So this is a clinical example of a choroidal melanoma, which is low reflective. And we're measuring diameters. Here's the optic nerve. But here's the illustrated example of how the ultrasound beam is cutting through the tumor. And the line in this case is the top of the screen, cutting through it this way in a transverse section. And here with the line at the cornea, it's cutting an anterior-posterior section or longitudinal section, seen here clinically. Here's a couple more clinical examples. Here's a mushroom-shaped melanoma. The A scan we remember, showing the tumor's apex, the sclera, and that 45-degree angle going down. And here we have the retinal detachment with the irregularly shaped choroidal metastasis with variable internal reflectivity on B scan. The next generation, which occurred in the 90s and unfortunately in ophthalmology disappeared about 10 years ago, is three-dimensional ultrasound imaging. I'm including that in this lecture because I believe that we will once again have 3D imaging as time goes by. But the concept here is we had A scan, which was a pencil. We had B scan, which was a two-dimensional cut. And now we have a third dimension where the two-dimensional cut is rotated and multiple two-dimensional images are collected by a computer and reconstructed into a three-dimensional volume. This was very valuable in ophthalmic oncology. This is the actual inside of a 3D ultrasound probe. You can see that the piezoelectric crystal is not only going up and down, but it's also rotating and collecting images for a 3D reconstruction. This was an example of a 3D image. I used to find that 3D ultrasound was particularly valuable for what I call the disorganized eye, post-traumatic eye, or an eye that had a hemorrhage and retinal detachment all at once. Here we have the retina with the vitreous, that clear vitreous in, but also you can see a choroidal hemorrhage here, here, and here beneath the retina. This is a volume of the entire ultrasound image, which allows you to dissect through and look at the subretinal contents. I'm going to show you another movie which demonstrates this very clearly. Here we have the three-dimensional volume that was captured. We're going to line it up, blow it up, measure the tumor with these calipers, and then we'll be able to interactively go through the volume, pull it out, and measure it again. You see this tumor is actually much different in longitudinal and transverse dimensions, much wider here. Here's an example of a retinoblastoma with 3D. When you're looking in with indirect ophthalmoscopy, you can't see the optic nerve. You just see this large tumor and another satellite tumor and some subretinal seeds of retinoblastoma. But on the ultrasound, you can see the retinal detachment, you can see the optic nerve shadow. So in this case, you can definitely see the tumor is not growing down into the optic nerve, which would be a bad prognostic finding. For more information about 3D ultrasound imaging and retinoblastoma, you might want to read the British Journal of Ophthalmology's paper we published in 2002. We also looked at using 3D ultrasound, particularly to look at the optic nerve in a C-section. Because we have a three-dimensional volume, we can actually recreate a coronal section of the orbit, which isn't possible with 2D imaging. You can read about that again in the British Journal. That was published in 2005. In another study, we looked at optic nerve sheath meningioma C-scans, and we were able to measure the optic nerve sheath diameter. As you can see, these two optic nerve sheath diameters are quite different. This is a normal 5.4 seen on the normal side of the patient. Here's their optic nerve on CAT scan. And here we have an abnormal 7.2 millimeter thick optic nerve sheath diameter where the meningioma is. This is one of a series of lectures that I'll be giving online, and I hope they're helpful for you in your practice. Feel free to contact me if I can answer any questions.
I want to take a moment to thank you for your attention, and to thank the Eye Cancer Foundation, who supported much of the research presented in this lecture, and for their committed support for international multi-center cooperation in ophthalmic oncology. Thank you and have a nice day.